disorder of the thyroid gland. So we have thyroid gland in order to secrete thyroid hormone, thyroxine, and T3, which are important for the metabolism of the body. And we will require iodine, which is a mineral that we will require in order for the follicles to develop properly. And in pediatrics, we may have different types of thyroid gland disorders, and the main ones being the hyper functioning of thyroid glands, where they secrete more thyroid hormones, or if they have a lower level of function, as in hypothyroidism. And so, uh, the first part is hyperfunctioning. So in hyperfunctioning of thyroid gland, which is called hyperthyroidism, we will usually have a secondary or primary type of hyperthyroidism. The primary type meaning that there's some kind of hyperfunctioning of the thyroid gland itself due to conditions such as an adenoma or a autoimmune disorder. And the secondary type is when you have a disorder of other parts of the body apart from the thyroid gland, which is located in your uh, larynx and or in front of the thyroid cartilage. And these other parts that can affect the thyroid gland can be pituitary or hypothalamus, where they will secrete TSH and stimulate the thyroid and signal the thyroid to produce more thyroxine. So the primary hyperthyroidism, as I mentioned, is adenomas, and other types can be due to autoimmune states like Graves' disease, where there are autoantibodies against the thyroid hormone receptors, and this will stimulate this will act as a thyroid stimulating hormone and stimulate the thyroid to produce and release more thyroxines and thyroid hormones, and this will eventually lead to the secretion of more thyroxine. And some symptoms that can arise as a result of this can be things like dry skin, exophthalmos, tachycardia, and weight loss, increased sweating, agitation and irritability. And some diagnostic methods can be things like detecting these antibodies or performing a test for TSH levels. And in Graves' disease, the TSH level will be lower because of the increase in the level of thyroxine. There will be a negative feedback, and the pituitary will secrete less TSH levels. And we will also talk about some treatment methods. So in these patients, we will divide the symptoms based on the tachycardia, so heart problems versus the thyroid problem. So for thyroid problem, we can block the enzyme synthesis and metabolism of the synthesis of thyroid hormones, which include drugs like proparothyrouracil, which will block certain enzymes in the cascades. While for heart problems, we may use beta blockers, which is a antihypertensive drugs that lowers the function of the heart and will attempt to prevent conditions such as heart failure in patients with an increased level of heart output and the workload in the heart. And in hypothyroidism, where there's a lower production of thyroid hormones. In pediatric, this can start in the congenital stage intrauterine, and this decrease in the level of thyroxine can lead to mental retardation and lack of proper development of the brain. And some examples include things like congenital hypothyroidism, and usually when your mother has a lower level of thyroid hormone, then this may also cause a lower level of thyroid hormone to pass the placenta and cause hypothyroidism, or or uh, or there may also be a chronic inflammation due to states like Hashimoto thyroiditis, where the autoantibodies against thyroid cells will eventually lead to the destruction of the thyroid gland, causing a hypofunctioning of the thyroid, and as a result, release less levels of thyroxine. And in these patients, we may see things like uh, po- failure to thrive, poor IQ, so intelligence may be lower, and may have short stature or growth problems. And some diagnostic methods to detect this is to detect a higher level of TSH or a reduction in the level of thyroid hormones. And some treatment methods for these patients will include applying thyroxine and T3 supplementations, while also, so mainly those two, and also like this low level of thyroid hormone can also lead to cretinism, which is another word for low levels of intelligence due to a low level of thyroid hormone. And also in iodine deficiency, there may be goiter, which is the hyperplasia of the thyroid gland due to the lack of iodine, which is important for the formation and functioning of thyroid hormone. And this will lead to a lump in the neck, which is due to the hyperplasia of the thyroid cells, and may lead to hypothyroidism as well. So that was about thyroid glands. Uh, so the next topic I want to talk about is increased sedimentation rate. So uh, in increased sedimentation rate, this is the meaning of erythrocyte sedimentation rate. It is erythrocyte sedimentation rate is a indicator for acute phase protein and during inflammations or tumors or inflammation reactions, and uh, it is measured by how many millimeters of erythrocyte is left in the plasma after 1 hour, and the erythrocyte sedimentation rate thickness is increased when there is a it is the theory is that the red blood cells will sediment into the bottom of the tube, and when there is less red blood cells or obstruction or fibrins that are obstructing the condensation of these cells to the bottom of the tube, then there will be a more quicker and increased sedimentation rate. While when there's more fibrin and more fibrinogens and more red blood cells, and basically the thicker the blood is, the less sedimentation rate will be present in the red blood cells. And as I said, it is an acute phase protein, so during inflammation, the rate at which the red blood cells condense will be faster. And the normal red blood cell sedimentation rate is for men 13 millimeters per hour, women 20 millimeters per hour, and for children around 10 millimeters per hour. And in increase in this erythrocyte sedimentation rate, we can see conditions such as anemia or or some auto-inflammatory conditions like uh, some chronic inflammation or cancers, and the for a reduction in the sedimentation rate can include states like uh, sickle cell anemia or or polycythemia vera, or um, because the blood will become viscous and the stacking will be obstructed. So, so that was some information on the increased sedimentation rate. And the next topic is monogenic disease affecting the skeletal system. So in this disorder, we will have osteogenesis imperfecta. And so monogenic disorders meaning that there's a genetic inheritance in bone formation and there's some effect on the bones. So you might have deformation on the bones intrauterine or postnatally or during the growth phase, and can lead to malformation in adults and may lead to death as well in some certain severe cases. So, in the first example of skeletal system disorders, I want to talk about osteogenesis imperfecta. Osteogenesis imperfecta is a poor mineral. It's a genetic disorder of poor mineralization of the bone, and depending on the type and the inheritance and the symptoms, we can divide it into four different types. The first type being the autosomal dominant type. It is also the least severe type and is associated with blue sclera or a thinning of the skin and exposing the blood vessels underneath. It is a problem with the collagen of your bones and all of the connective tissues, and will lead to brittle bones, and there will be a lot of fractures during the pediatric period and can lead to certain uh, bone malformations and uh, these malformations. And for the second type, it's the most lethal type, and it's one with the most severe symptoms of these, as I mentioned, bone fractures, and these bone fractures will be present during the intrauterine period, and basically the bones will break inside the during the pregnancy and cause limbs to shorten, and also during the postnatal period there will be severe scoliosis and chest abnormalities, which will cause the lungs to collapse and not be able to breathe properly, causing death. And this is the lethal form of osteogenesis imperfecta. It is also autosomally recessive inheritance, and type 1 is dominant inheritance, autosomal dominant inheritance. And for third type, which is also a very severe type but non-lethal, it's also autosomal recessive inheritance, and this will also cause various malformations and fractures and blue sclera. And for the fourth type, this is the mild type, and this is autosomal dominant inheritance, and it will is associated with a slightly milder form of fracture. And so we can diagnose this disease using X-rays and see if there are fractures, and also by clinical symptoms, and also by the level of gene testing where there's a mutation in certain genes of the bone, such as collagen forming DNAs. And the surgery, the treatment is done by providing growth hormones and bisphosphonates to increase the mineralization of these blood. So for the second uh, example of skeletal muscle disease is, or skeletal bone disease, or osteochondrodystrophic dwarfism. So this is a type where it causes a malformation in the bone cartilage, uh, which is important for the growth of long bones, and it's the main cause of dwarfism. And there are many different types of osteochondrodysplastic dwarfism, depending on uh, the location of the lesion. And one of the examples is achondroplasia, which is autosomal dominant inheritance, and there's a complete lack of there's a mutation in the uh, plate in the metaphysis, and resulting in very short stature, around 4 feet 11 inches, and there can be some skeletal problems associated with it, such as joint problems or bowing of the legs, and certain facial features like wide forehead or wide nose bridge, and some diagnosis can be also done by X-rays and to look at the bone metaphysis, and also for the treatment, we can perform surgery to fix deformities in the bones. It is also possible to perform growth bone extension surgery to make the bones longer, or uh, to uh, correct the bowing of the legs by surgery, or also growth hormones are said to not be effective in treating these osteochondroplastic diseases because it's not very effective, and there are some other options that can be used for treatment of dwarfism, osteochondrodysplastic dwarfism. And the last type I just want to mention is hypophosphatemic rickets. This is a type of so rickets is basically osteomalacia for the young people, and in hypophosphatemic, this means that there's a low level of phosphate in the blood that causes the softening of the bones and bowing of the bones, and this is due to the body being resistant to the function of vitamin D, which is important for the reabsorption of calcium and phosphate in the intestine, and this will cause the low levels of phosphate congenitally as well as for the rest of the life, and this will result in rickets or the symptoms of bowing of the legs, weakening the bones, bending of the bones due to the poor phosphor mineralization of the bones and hardening of the bones. And and so those were some examples of a bone disease that is affecting the skeletal system, which monogenic inheritance. And the last topic I want to talk about is congenital anomalies of the gastrointestinal system. So these congenital anomalies of the gastrointestinal system include various level and variety of malformation to disorders in the gastrointestinal systems, and can either be due to teratogenic causes or infections or genetics or simply spontaneous mutation. And to start with the esophagus, we may have tracheoesophageal fistula or um, gastroesophageal reflux diseases. We may also have esophageal atresia. On the stomach, we may have a pyloric stenosis or gastric rupture or perforation. And on the duodenum, we may have some stenosis or malrotation. And for the cecum and colon, we may have Meckel's diverticulum. And Hirschsprung's disease may occur around in the colon, and gastroschisis is when you have a poor membrane formation or the abdominal wall formation causing a uh, herniation of this intestine to the abdominal outside the abdominal wall, and omphalocele is when there is a membrane around this intestine wall. In gastroschisis there will be no membranes around the intestines, and and so those are some examples of uh, congenital anomalies of the gastrointestinal tract. So starting with tracheoesophageal fistula. This is a disorder where there's a atresia in the esophagus, meaning that there's no connection between the esophagus upper and the lower esophagus, and there's a sudden stop there. And on the other hand, there's a fistula between the trachea, which is the respiratory system, and the uh, esophagus, and this can cause various symptoms such as aspiration pneumonia or suffocation or poor oxygenation, cyanosis, and may cause death as well. And it may also cause bubbling in the stomach or um, a thing like this. And tracheoesophageal fistula can be divided into five different types, from type A to type E. And type C is the most common one, where there is a esophageal fistula between the lower esophageal fistula and the upper and the trachea, and the upper esophagus is atreused, so there's no connection to the lower esophagus. And and some symptoms, as I mentioned, is respiratory infections or aspiration pneumonia, respiratory failure, and bubbling from the mouth or vomiting milk, and some poor failure to thrive, and jaundice. And the testing can be done by performing a nasogastric tube and X-ray, and to see that there's a coiling of this tube within the esophagus, indicating that there's a atresia of the esophagus. And endoscopy or uh, contrast mediated uh, visualization of the disorder should not be used due to the risk of respiratory failure or obstruction of the respiratory tract or aspiration of this contrast material. And the surgery is performed in these patients by either performing a fistula between the lower and the upper esophagus, and taking out the fistula between the esophagus and the trachea. And if this is not possible to do it in one procedure, then we can first perform a procedure of separating the trachea and the esophagus, and then elongating the esophagus, and then connecting the esophagus. So another example is the last thing to mention about tracheoesophageal fistula is that there is usually a syndrome associated with it called the Vacteral syndrome, or it's various symptoms that tend to occur together with tracheoesophageal fistula, and this includes some vertebral anomalies or anal atresia or cardiac anomalies, as well as this tracheoesophageal fistula and some limb anomalies. And sometimes uh, there may be some renal problems, and sometimes there may not be any cardiac issues associated with it or limb associated, and in these cases it's called Vactor or Vater. And So that was about tracheoesophageal fistula. And for pyloric stenosis, is a condition where there's a hypertrophy of the pylorus of the stomach, and this is usually due to the muscular layer of the pylorus, and this will lead to a poor emptying of the stomach and causing some projectile vomiting of milk and poor feeding and failure to thrive. However, after vomiting, usually the patient becomes hungry again and will eat again, but then will vomit again. And and So in these patients, the diagnosis is done by X-ray or a gastroscope and or ultrasounds to detect the lump in the stomach, and also there can be a manual palpation of this stenosis due to the hypertrophy, and some treatment methods is surgically by removing the hypertrophy by drawing out the muscular layer and performing a suture of this muscular layer to the more serosal layer to reduce the resistance. And for malrotation, we may talk about the shortening of the duodenum or the diverticulum of these walls, causing a intestinal rotation and ischemia as a result, as well as ileus. In gastroesophageal reflux disease, this is where we have a lower pressure of uh, lower esophageal sphincter, and this will increase the level of vomiting as well as poor feeding, and some diagnosis to be done about uh, this gastroesophageal reflux disease is by monitoring the level of pressure on the lower esophageal sphincter using a monitor, or you can also measure a 24-hour pH monitor to see if there's some reflux of the acid from the stomach into the esophagus, or also a so those are the main types to diagnose reflux disease, and some surgery can be done by, I mean, it might not be necessary, and if the case is severe, then we may give a surgery to, so it's called, um, uh, uh, it's a particular surgery where the cardia of the stomach is wrapped around the lower esophageal sphincter in order to create this sphincter and to reduce the level of gastroesophageal reflux. And so, and in Meckel's diverticulitis, this is a diverticulum that's forming in the ileum of the small intestine, and in these diverticulum, it's an outpouching and can have various levels of gastric cells in it, and it can secrete this hydrochloric acid, which may cause inflammation of the intestinal mucosa and ulceration, as well as these reddening or these changes within the mucosa, and it may cause inflammation as well as perforation in severe cases. So usually these are removed surgically. And the last one I want to talk about is Hirschsprung's disease, where there's a basic lack of vessel nerve plexus of Meissner and Mantoric plexus in the large colon, causing a narrowing of the lumen of the colon, and this will lead to a blockage of feces, causing an expansion in the 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 intestine and causing constipations and a large abdominal mass. And in these patients, usually surgery is performed to remove the portion that is causing the stenosis and combining it together with the part that is normal or a yes. So those are some of the treatment methods that are performed for congenital anomalies. And yes, that's the end.